Good afternoon, everyone. My timer has started, so I am going to get started as well because this is going to get very exciting today. My name is Anjum Ahmed. With AGFA Healthcare. I wanted to welcome you all on behalf of AGFA to this lunch and learn session today. The topic, as you can see, is from shortage to strength and how networked radiology and AI will help enable sustainable imaging future. So we have multiple topics today, and we will look forward to interacting with you, getting your questions as well, and an open participation in the session. My name is Anjum. I'm the Global Chief Medical Officer for AGFA Healthcare and the Global Director for Enterprise Imaging and AI. I've been with AGFA Healthcare for over 12 years now, and primarily focusing on the pre and post medical follow up on patient risk and safety, and also the emerging innovations that we are embedding with enterprise imaging. With me on the panel are Dr. Peter Strouhal. He comes from Alliance Medical, and they're a very large group. They have done some very pioneering work. Dr. Peter himself is the medical director at Alliance since 2020, a practicing consultant focusing on and specializing in PET CT with over 20 years of experience. So we'll hear from Dr. Peter Strouhal how they have been leveraging enterprise imaging, how they have been leveraging cloud enabling technologies, some of the pioneering work that they have done in the UK and internationally as well. With me, also with us on the panel, is also Dr. Athanasios Chalazonitis. Correct. I know, thank you, thank you. And he is from Athens in Greece. I've been to Athens and multiple times. It's an amazing city. He is the chairman of radiology and director of medical services at the Alexandra Athens General Hospital, which is a major academic center specializing in gynecological and oncology imaging. We'll learn from him how they have been leveraging enterprise imaging for broader, networking, imaging, teleradiology aspects. Also joins us in this session today is Dr. Filip Dekkers. He's a radiologist at ZAS Hospitals in Antwerp, Belgium. Antwerp, the city of diamonds. Yes, and he has broad clinical experience and expertise. He has also pioneered, not only the transition with enterprise imaging, but also with the ZAS group of hospitals in Antwerp region and how they're unifying and expanding their portfolio of radiology departments. And he's also been at the forefront of implementing innovative AI solutions, which we will also be talking about and learning from their experience, and how we at AGFA Healthcare are also learning from some of our esteemed panel members here. Dr. Davide Ippolito, he comes from University of Milano Bicocca, also pronounced correctly, thank you. And he's the head of emergency radiology and innovative imaging at the Foundation IRCCS San Gerardo in Monza. He's associate professor at the University of Milano Bicocca, over 20 years of experience with innovative things in radiology and imaging that they've been doing. We will also learn from Davide, Dr. Ippolito, how they have utilized enterprise imaging not only to consolidate workflow, improve workflow orchestration and these capabilities, but also integrating and embedding AI into your daily and routine practice. Key takeaways, just wanted to make sure, the session remains structured and we're able to guide you also if you have any questions in mind. I'll begin with an initial summary about how we have evolved with enterprise imaging. You've heard a lot about PACS, and now you're hearing about enterprise imaging. At AGFA Healthcare, we also talk about the future of enterprise imaging to becoming a system of intelligence, and how this system of intelligence can enable network radiology, whether it is cross-border collaboration, not just within your hospital, but outside as well, because connectivity, sharing, collaboration, image exchange, teleradiology. Many people have different definitions about also teleradiology and how it's integrated. We'll gain insights on AI, practical experiences, how they have been leveraging AI. And we'll take your questions as well, because that's how we all have lunch and learn sessions together. Now, what do we do at AGFA Healthcare? This has been an amazing few years at AGFA because with our flagship enterprise imaging platform, we have been also recognized as best in class for some of our capabilities because, as I mentioned earlier, we expand beyond the traditional radiology imaging archive. We were the first ones who introduced the concept of enterprise imaging and how we build this platform from the ground up so that it not only serves your departmental needs in the radiology, cardiology, or other ologies, but it also allows to expand and collaborate with multiple entities within your network, outside your network, and how you collaborate and work together. Which is the reason how we have this diverse panel here, because this integrated radiology, we believe, is becoming more and more important than ever, because it is also influencing, as we will talk about, how artificial intelligence is now getting embedded. How radiology is evolving, what we are learning is that imaging is moving from interpretation, or the radiology practice itself is not just about interpreting imagings anymore. It's more about clinical intelligence and how we believe radiologists are becoming, the central hub of data intelligence, and how this data intelligence can be used, moving away from single studies to longitudinal patient journey, instead of looking at AI as isolated tools that we used to integrate 10 years ago, towards more enterprise orchestration, that how these tools can be used to influence and improve workflows. So it's not more about pixel accuracy, it is more about measurable outcomes. And this is what we believe in, that how AI can impact pathways. So it's beyond the pixel or identification of how AI picks up certain things. It's more to do with pathways. Why? Because the change in radiology is not temporary, it is structural. When we see what's happening in the UK, when we learn what's happening in the European region and countries here as well, the growth and of imaging, the advancements in image acquisition and at the modality level as well, it is influencing how radiologists view images. And it is also then challenging solution providers like us as well. How can we improve that user experience, and not only in terms of how you view those images, but also how you work and collaborate with each other, because platform intelligence is the missing link that needs to address this. So how do we build this foundation, and how do we bring all this together? In the first part of our session, we will discuss, first of all, focusing on enterprise imaging as a platform and strategy, and how our thought leading customers are not only building on this framework, but also collaborating with each other, and also addressing some of the challenges related to governance and teleradiology. So I'll start with you first in Greece, for example, what you have done. And when I think about your experience with the edit, across 380 remote sites that you have connected, in terms of how you bring structured integration together, what were the biggest governance challenges in implementing a national teleradiology framework, and how did enterprise imaging help you address some of those?
Okay, thank you very much. Hello, everybody. I think you have a great lunch because everybody stopped. You finished your lunch, so it's quiet now. And I'm trying to give you the Greek view about teleradiology. First of all, I would like to thank you because you use the term teleradiology instead of telediagnosis, because teleradiology is a medical act, and we have to face it like a medical act. It's not a technical procedure. So everybody needs the doctor, the radiologist, somewhere to be follow the examination and then to report the examination. It's a medical act, and this is how you can help us to create the digital radiologist to be in every place. In Greece, we have a quite fragmented system, healthcare system, because we have so many islands, and we have small health centers in the islands. We have a lot of remote villages. We have some big university hospitals. One of them I am in one of them, I work there. We have a very strong public sector, and we have a lot of public diagnostic centers. So everybody works in a different way, and we need a framework about all these people to coordinate and to collaborate. So it's very difficult in countries like Greece to have a whole digital system for teleradiology. And then we have to start to design something. I'm going to give you our paradigm in Greece. We have to start to design the system, the whole procedure, from not only from the technical aspect, but for the needs. We need to report more and more examinations per day. You mentioned 3 to 8% increase every year. Add to this the screening process, and what we find after screening process, more and more examinations, and we are the radiologists, we are in our countries, so it's very difficult for us to be in all the places. So what can we do? We must have the same quality, the same standards, even the radiologist is on site or the radiologist is somewhere else, the remote or digital, call it whatever you want. But the radiologist must design the examination, the whole procedure. What about contrast media, initiation of contrast media? What about reactions? What about adding some more examinations like CT, MR, whatever you want? So in every time of this procedure, we need the radiologist to be in present, remote, I believe. So let's try to invade, to make them digital radiologist. And because in the center of our actions is the patient, we must ensure that we have the same quality about this examination with the radiologist being present. So this is the main problem. So we need your help. We need your help, I repeat this, to ensure that we have the same procedure anytime.
Absolutely.
For every patient.
Absolutely. When you speak about patient, and when I think about this networked radiology or teleradiology, now wearing my CMO hat, the patient safety perspective as well.
Yes.
So how do you ensure patient safety and data protection in this kind of a network?
Yes, great question. Data protection. This is very, very important. We must have a framework. We must follow GDPR regulation. We must know who is going to use this data, who is going to be responsible for this data, who is going to be responsible for the clinical questions, and who is going to manage the whole thing. So we need a very strong and very powerful environment to handle all this data, huge amount of data. So the first one is to decide who is going to be responsible. Second one is to decide, is the remote radiologist or the digital radiologist responsible for his diagnosis, or the owner of the installed MR or CT? So you must have rules for everything and try to know about everything which is going to happen, because in the case of a mistake, a misdiagnosis, who is going to be responsible? We always have to face the patient in front of us and tell him that we are, but who we are? The on-site, the outside, the digital one. So we need a framework. That's why in the next month in Greece, the Minister of Health is going to release, I think we will be the first European country to release a whole framework for teleradiology in order to answer or try to answer all your questions.
Excellent. I'll look forward to this, because
I will send it to you.
Thank you. But before you send it to me, I still have another question, because it's opening up in regards to, because I believe you serve underserved areas also in your network, right?
Yes.
So
yes. We have different areas. As I told you, we have all the islands, we have the small villages on the mountains, and we have the public sector. Because of the shortage of radiologists, we have to combine all of them and to make them together with a structure diagnosis. We must use the same protocols. For example, how we examine, how we perform a CT of the pancreas. We must have protocols for everything. So we need a radiologist in chief as the medical director, and we need a radiologic technologist in chief to design all the protocols with him. And we need, of course, a physicist. So it's a team. It's a whole team working for a framework.
So that's what then when I think about this, how you have expanded the use of enterprise imaging outside the traditional domain of radiology as a department, bringing all this together. And I'll thank you for
We don't expand. Sorry to interrupt you, but we don't expand. We are in the same environment, using the technology. I work here, and I report images from Corfu. My wife is a radiologist too, and we work from the house. But we are in the hospital because we are in communication with the team who is performing the examination. We need all the clinical information. We need priors. We must have everything just like being in the next office. Imagine, I don't work in the MR unit. I work in my office in the hospital. So it is the same. The distance is longer.
Absolutely.
But
Absolutely.
I am here. I am there. I am everywhere.
Thank you. Thank you for being.
That's why my name is Athanasios. I explained to you the meaning of my name.
Absolutely.
Later on, if you have a question, I'm going to explain you why. What is the meaning of my name?
That's.
I am everywhere. Remember.
Thank you. I'll move forward with Peter with how you have been, not only at the level of working inside the NHS and hospitals in the UK, but you as Alliance Medical as a group, I think one of the first ones in leveraging cloud technologies and expanding with teleradiology and imaging. So please share your experience with
Yeah, so just for context, Alliance Medical provides CT, MRI, PET CT primarily for the NHS. But the NHS isn't one thing. So forgive me if I'm going to burst a big bubble here. The NHS, when you look from a distance, looks like one big ship. And when you get up close, you realize it's about 200 small little boats that are all sort of sailing together roughly in the same direction. And the technology around it is similar. And Alliance actually works in a similar way that marries that. So in some places, we are part of the radiology department. In some places, we are a truck in a car park doing scanning. In other places, we are the community diagnostic center, where there might be MRI, CT, X-ray, ultrasound that serves the outpatient community adjacent to, but actually remote from a hospital. So we have all of these disparate locations. We partner with about 100 major hospitals across England. So although it's not a big country, that's a lot of locations and a lot of different types of imaging locations. So what we were struggling with was we were on premise. So we had, I think, 84 physical servers around the place, connecting not just to the local hospital packs, but trying to connect back to our network. And it was trying to manage all of this imaging. And we had a pool of radiologists that were then managing some of those scans. Some of the imaging was happening and we weren't reporting it, and it was going back to trust for them to report in-house. So we had a real mixed estate of where we were scanning and reporting, where we might actually be doing other diagnostics. So in some of these community diagnostic centers, there's blood tests, there's endoscopy, and all of that has to be bundled together so that the patient gets the right care. And in terms of the NHS, it is one system in that it doesn't care where you do it so long as the patient is at the center of everything. So we had to marry that. Now, we were kind of lucky or unlucky. We got to a point where what we were using were legacy systems that were no longer supported. A bit like suddenly running Windows 7 and the license is no longer valid. So we had to change. And the question was, were we going to change, update what we had, or were we going to go whole scale and move to the cloud? And we took the second decision because we decided that was a way of making sure that future upgrades were easier, future integrations with AI, and I know we're going to talk about AI later, but all of those new technologies are much more readily accessible and scalable if you've got one platform to integrate it with that's on cloud. So that's our kind of backstory, but ultimately we support the NHS, so we had to have a means of integrating whatever we did back to the NHS to make sure that the patient information is always where it needs to be. And we went through that big tranche. We went round all of those shiny stands out there, and AGFA's, of course, is the shiniest and brightest. But there are others, and we went round them all, and we whittled down to who we were going to go with. We had our own criteria as to what we wanted and why, not just now, but 7 years' time, the length of the time that we've signed the collaboration for, and what Alliance's roadmap was, and how we were going to be supporting patients in the NHS for all of those years. And we decided this was the way to go. And in a way, only you will know exactly what your local journey is. It's much easier if you're one hospital, but we effectively were multiple small hospitals, imaging facilities, and we needed to find a way to tie it all together. And the simplest thing was an enterprise network.
You went through a very structured exercise when, remember we first met, and it was a couple of years that the whole process kind of evolved. Your selection criteria when it comes to enterprise imaging, if you were to, share with the audience, what were the three top takeaways or criteria that really said, AGFA?
So I guess the simple answer is, and some of it has some commercial sensitivities around it, but let's break some of those barriers here, because we're amongst friends, right? We've all had lunch together. We're friends now.
Yep.
Or we haven't had lunch, but we will. But essentially, we looked at what our company roadmap was going to be, and it's no secret that we wanted to do more community diagnostic center imaging, because that is the direction of travel for patients in general, but the NHS in particular. Lung cancer screening has been running for a few years, and that's expanding in the UK. And we are part of that, and that's only going to grow, and other screening will come. Prostate cancer screening, I think, is imminent, although NICE are doing their best not to approve it, but I think their arms will be twisted soon. And then dementia imaging, depending upon if the blood test that was talked about last week takes off or not. If not, I think imaging will grow on the back of that, and that's all coming. So we had some of those growth models in mind, and we were thinking that is where we want to go, and we need a platform that supports that, not just where we offer it, but integrated across everything we do, because we, across our system, for example, so we deliver 175,000 PET CTs a year. And that's a number I'm really proud of, because it's one of those numbers that whether you're at ECR or whether you're at RSNA, nobody has a number bigger than 175,000 PET CTs a year. And on top of that, we make the isotope. So we have the logistic challenge of making sure the isotope gets to where the patient is to have their cancer scan in a very timely fashion, and it doesn't slow up any patient pathway. And we were also thinking that that needs to feed research, that needs to feed other new developments, it needs to feed new tracer. And we needed something that connected all of those things and the 200 radiologists that read our PET scans wherever they are. Back to your point about being everywhere. Well, we don't want to be everywhere, but we want our network to be everywhere. Same thing, really. But that's the point, and that was the solution we needed. And that was why we looked at where we were going. And so our key criteria, to be blunt, AGFA came out on top, and that's why we are where we are. But it might be a different one for you in all transparency. You might look at what your local roadmap is, what your screening is happening in your country. It might be subtly different, and you might get to a slightly different answer. But I think you have to plan what your roadmap is likely to be and find the right match.
Yeah, it kind of blends together both the clinical and the IT infrastructure. You were mentioning earlier this morning how you have reduced the points of failures, right, with this strategic approach. And that's where you realize your teams are also realizing benefits in terms of how this scales out.
Yeah, so we had our scanning technologists doing a scan and saying they finished the patient and the system would upload the images. Well, where?
Yeah.
To the local scanner, and then the local node on our old network. And we would have a radiologist sat in a different part of the country saying, well, I'm ready to report the case, but I don't see the images. And on our old system, there might be something like 20 potential points of failure, maybe even more between those two. So our technology team had a really difficult job to work out where that blocker was. I'm going to simplify it because I'm a radiologist and I'm not a technology person, but essentially now you have a scanning facility wherever and it uploads to the cloud. Our team in central office, the admin team, can see it's on the cloud, and the radiologist can say, I can't see it. Well, they can now pinpoint exactly where that system has failed in a much simpler way than thinking there's 20 points of failure. You've sort of only got 2 or 3 or 4, but it's low numbers, and you know exactly where the problem is. And even better, if you can't fix that problem for that radiologist, the scan is on the network. We have 199 other radiologists on the network that one of them can pick it up because it's a properly integrated network. It's properly on the cloud. It's truly available all of the time. So it's taken out so many points of failure that it gets over that hurdle of, is it risky to go onto the cloud?
Absolutely, and that's the whole premise around interoperability and expanding to the enterprise. I want to move forward because everyone wants to understand how we integrate AI into this story and how artificial intelligence plays a particular role. The feedback that we have generally received from some of our early adopters and customers have been around the shift in the industry over the first 10 years of development of AI from detection, triage, and that shift is moving towards outcomes. What KPIs are we able to monitor in real time? The trust and explainability aspect is also becoming more and more relevant. So the way we look at enterprise imaging is that it has helped our customers build that infrastructure with this platform strategy kind of becoming that nervous system of the hospital, where embedding AI applications, whether we delivering those AI applications to our customers or customers' own choice of AI solutions, or the ones they are developing as well, kind of becomes easier to embed. And that's where, the question is, how do we make it work? So I had the pleasure of working with Dr. Deckers and the team in Antwerp at the GZA. They had a very interesting exercise that they did a couple of years ago when they were evaluating how they will embed AI into enterprise imaging, but also how, before they even decide how you will use AI, you had a whole exercise around evaluating. And we had interesting session with your group of radiologists where we sat down in the room. You had all the anonymized exams and we were looking at the results. Share your experience, first of all, how enterprise imaging helped you lead towards this approach with AI.
Well, first of all, there's always the big elephant in the room. I'm head of the department, and the responsibility is not only for the quality of the imaging, but I also need to keep my department and my hospital financially sane.
Yeah.
So first of all, if you buy an AI algorithm, you need to be sure that it's fruitful, it has a benefit. And for it to be beneficial, it has to be used. And we all know that in change management, the human side is the most difficult to cope with. So we wanted from the start the AI to be completely embedded. We wanted to be always on, and we wanted it to be used by all radiologists. So that requires us to build a system where trust is essential. So what we did, we asked our own radiologists to hand us a number of scans, and in the sort of a pilot system, we sent those images to the AI developer, to the AI company, a small batch, 30, 40 images. They came back with the results. We had our radiologists have a look at it. And then we decided if it was good enough for us. Of course, it's being tested by the company that made the algorithm. But that's a reassurance for the radiologists that it also works in our cases. And with that, we can build trust. And we saw that by adopting this way of integrating the AI system into our workflow, radiologists really were eager to start using the AI system. And that's what you see here. most of them started with a lot of trust in the AI systems right from the start. Some of them, it took 3 to at most 6 months, but everybody is using it now. We are using it mainly for cancer screening, but also in the ER department for fracture detection. It does help a lot, mainly in quality. People are more reassured. Of course, you also have the doesn't grow fatigue like radiologists do. We have a huge number of scans we have to read, which can become very fatiguing by the end of the day. So we did a little poll. You were there.
Yep.
With our radiologists and asked them how satisfied they were with the AI systems we acquired, and they were pretty satisfied actually. They were convinced of the added value because the AI highlights the areas where it's difficult, so they could concentrate on that area. And what we didn't expect is that the AI system also reduced the inter-observer variability.
Yeah.
And that's something, especially in oncologic settings, very important, because that was one of the criticisms we often got from our clinicians. Well, radiologist A says this, radiologist B says this. And how is the reporting? Because they have a report of half a page. He's just writing 2 sentences. The AI also incites us to give more structured reporting, and that's something they really appreciate.
Absolutely, because you started with one imaging area in breast imaging, where you started with AI, and then you expanded into MSK, fracture detection, and those use cases. So that also kind of signaled the confidence that the users were developing the way these algorithms were embedded in enterprise imaging. But there is also a shift and transition that took place with your group, right? Because you started with GZA as one hospital, and so how do you see that transition?
Well, with GZA, so just for the audience, GZA has 3 campuses of the 8 campuses within ZAS. So we are more than doubling our capacity. We were at the forefront in including AI in our systems, and it didn't take long before the other radiologists, and especially the other clinicians, to come ask for our colleagues from the other campuses to implement the AI systems. One of the major parts, one of the major demanding parts was the emergency department. They were really eager to implement the fracture detection, because for them it's a lot of change. It's the turnaround times of the patients go down. The quality of their services is improved. For us, beneficiaries, they call us less at night. So it's the driver is not only within the radiology department, but within the entire hospital to adopt this soon. Yes,
Absolutely, and I'll move to thank you for this feedback, because your teams have been really helpful. All the radiologists, when we sat down together, we did the survey and the poll. There were very important takeaways in terms of how the integrated experience within enterprise imaging has been helpful for the users. Building that trust with the use of AI. In Italy, you have implemented AI as well, and you have implemented the MSK, the fracture detection solution.
Exactly. Yes, since I'm the head of emergency radiology, I would like to say that the emergency area is the most important one.
Of course.
And that deserve the AI support. But it is, because during the night shift, we work for 12 hours, and it is really brain demanding. And so we need support, a good friend that could help us in a really challenging condition. And for this reason, we love a lot the several algorithms, like the one dedicated to bone fractures. And we know that maybe in a pediatric patient where the alteration, the fractures are really subtle, having a support from AI is fundamental. But not only to make the diagnosis, but also to avoid multiple projection. We can reduce it. We can avoid to do the contralateral X-ray examination. So it is important for the diagnosis, but also for the patient safety. And I think that in line with that, also having a lung analysis assist could be really useful, because the system is able to recognize pneumothorax, lung consolidation or lung nodules and pleural effusion. And obviously, when we are in front of a really challenging condition, we have an important trauma in CT, but at the same time, we are acquiring a further and further examination. Now we are facing off to the continued increase of radiological examination, having a support as mandatory, something that is in line with mammography. We know that we have the second opinion, to look with 2 different readers. I think that now in radiology in the next year, we have the second reader, but will be represented by the AI, and it will be fundamental because we have to face off to this increasing demanding of examination.
How have you seen the acceptance of AI when you integrated for the rest of the department and other radiologists? Does it take time to get used to the integrated experience with AI?
Yes, obviously, everything is new, needs time to become accepted. But at the end, if you start working with something that at the beginning you cannot trust, but you can see the results, because in our center you have the possibility to look in the viewer and the workstation, the native images acquired from the radiographers, and the second capture from the AI-based tool. You can make your own diagnosis, and you can look at the second opinion and say, yes, it works, it is useful, and it is something that grows day by day, the trust between each other. And I think it's in line also with Google Maps. I think that everybody use Google Maps to drive, to go to the straight point. Everybody hates wasting time in queue. And it is an AI-based tool. I am the driver. I know the route. But if someone can give me an advice, avoid this route in order to save time and go directly to your objective, it's the same. So we need of it.
Absolutely. So did you also, like Dr. Deck has mentioned, they went through a trial phase, the evaluation. So did you follow the same approach in evaluating a multiple kind of set of solutions, or was it based on the scientific evidence that the developers provided you? How did you decide that this is the right solution for us?
Obviously, the testing of solution is the most important one. So again, we need time to become confident and gaining some trust on the software. So we have to understand if the solution are important for our center. Because for the emergency setting, we need something. But for oncologic field, we need different AI solution. Maybe those solutions that are avoid us the wasting time procedures. I don't know, measuring the cyst in patients with polycystic disease, or making the evaluating the entire volume before liver transplantation. It's not challenging for our mind, but it's important for the surgeon. So if I can save this time in making diagnosis and avoiding to do procedure that is not so important from our mind, it is the correct choice. So you have to decide according to the needs of your hospital which solution you need more and how to invest your money.
How did you find experience working with AGFA Healthcare's local teams in supporting you in this?
As you know, we have a really long history relationship. We started with them more than 25 years ago with the first impact system. And so I would say that relationship is great. We have a lot of support. We test year by year the new products, and I cannot say only good words for your team and for the...
You can say all the good words.
Yeah, exactly.
Thank you. No, this has been an amazing journey, as you can already feel it and hear it from our thought leading customers here. The journey has been a journey of not only technology enablement, but also how the solution itself has also allowed our customers to scale. When it comes to AI, the way I like to summarize this in terms of how we have developed this Ruby framework within enterprise imaging is orchestration of these different findings. You know, all algorithms generate ton of data, and different algorithms have different way of providing that output. So the way we orchestrate intelligence is part of this Ruby framework that we have developed. Workflow native integrations. Since the outset, what we decided was we will not have multiple widgets or tools kind of integrated so that radiologists will have to press a button to launch a particular result. we wanted to make the user experience seamless. And please do visit our stand as well, so we can show you how in action it really looks like. It looks like they are within enterprise imaging. It doesn't look like it's a separate system that is being, so that is what has allowed us multi-algorithm enablement with our packaging approach with AI. Now, I wanted to move forward because I wanted to get perspectives in terms of what's next. You know, all these emerging innovations that have impact in terms of ethics, interoperability, and also the challenge related to how, and Dr. Strouhal, I'll start with you as well, because we didn't speak about AI yet with you, because you have a huge, you know, as Alliance Medical Network, how do you see AI getting, you know, when we think about your strategy and your priorities with AI, and also keeping in mind the different geographical boundaries that you will operate in, the regulatory aspects, the interoperability and ethics?
So I will share with you what I think is my kind of cheat code, and I think it's applicable in a lot of the territories around the world. And I'll preface that by saying I'll leave my colleagues, my esteemed colleague here, to talk about what I call sexy AI. Sexy AI deals with the pixels.
Yep.
I think you can actually leverage the non-sexy AI, what I call dirty AI, much more easily. Now, what do I mean? I mean, if we're talking about an AI that gets under the hood, as the Americans say, under the bonnet, that rolls its sleeves up, that will get dirty and deliver you real results. What I'm talking about is an AI that can do your scheduling, your booking, your protocol optimization, your predicting no-shows of your patients, working out your geographies for logistics if you're moving mobile scanners around. The nice thing about that, why I call it a cheat code, is it's dealing with data, but not patient data. So it's not a medical device. It's actually in a safe space, and it's actually a way that if you can optimize how you scan, how quickly you scan, you can potentially use your scanners much better. And we've shown this where you can actually increase your throughput such that a department doesn't need a new CT or an MRI, because you can add 40% extra scanning capability. So you save money on that front. And if you're getting paid for each scan, you're generating income that you can then put to one side and buy your sexy AIs that my colleagues are going to talk to you about. Yeah. But I think that relies on business intelligence data. And I don't want to get too technical, but I'm happy to pick up later. But essentially, business intelligence data is the stuff that doesn't track what the patient journey is. It tracks one patient journey compared to another one. That's how it can predict the no-show, because it can look at the fact that you've got 20 patients coming in the afternoon. It will look on Google, other search engines, what the prevailing road conditions are, what the weather looks like, how old the patients are that are coming, and it might say that your 3:30 patient, who's a 95-year-old lady that normally gets a taxi to the hospital, because of road work, she's going to be late or she's not going to turn up, and you're going to have a gap. And you can decide what to do with that gap. You might double book into that gap. You might move the other patients around, finish your day early. You might do what we did, which is we condensed our scanning and we gave all of our staff their lunch break back. Now that's quite an interesting model. Instead of scanning 12 till 1 and doing 40 patients, you scan 9 till 1 and doing 40 patients, you scan 9 till 12, and at 12 everybody stops and has lunch together. There's no money there, they're not getting paid extra, but it's a different work environment if they've got a lunch break. That's AI. So that's an interesting model, and that's my cheat code. And that's what we have been using for a long time, but that's built on the fact that our network talks to itself. We can track one patient relative to another on an enterprise imaging network. It can scrape that data out that actually is quite hard to otherwise get hold of, and you can suddenly start to see gaps in your practice service and your service delivery that is not otherwise obvious. And you can then save some money and buy some really nice AI that I'll let you guys talk about.
How do you see this from, you know, when you're in a network radiology or teleradiology, as you say? How do you want to see this deployed? Whether it is, because when I think about radiology, I also think about, you know, radiology from 3 different angles. There is the pre-acquisition phase, there is the image acquisition, and there is the post-acquisition. Today, most of those sexy algorithms are in the post-acquisition phase, right? That's where the pixel identification comes. But as you rightly said, the value is on the other part as well, which is the functional operational. So how do you see, for example, your experience in Greece? Do you have a strategic approach in terms of how you want to see AI deployed in either of the end-to-end life cycle somewhere?
To answer to your question, I don't know, because nobody knows the future. And I want to remind to you an old film. Do you remember the film Minority Report?
Oh yeah.
24 years ago, Tom Cruise was predicting the crime. So who could imagine 23 years ago that there was a system that who is going to predict what is going to happen? So I don't know. I think that in the near future, not in the far future, we are going to see huge changes. So we have to adopt with these changes and to use them for our patient. And from my point of view, according to AI and teleradiology, I think that I will divide not AI in three. You said
Categories.
categories. I'm going to divide radiologists in three categories. The first one is, let's say, a not so good radiologist who passes the examination and can act with everyday practice. This one will disappear with AI. We don't need him. You don't agree with me.
You could say that the AI will improve.
No, I'm going to
Okay.
I will finish with
Okay.
this. Middle radiologist, who he will go with AI together, hand by hand.
Mm-hmm.
And he will be better and better and better radiologist. But let's talk about a brilliant radiologist, one of these speakers, because from your talks, you are brilliant radiologists. I think that you will be like a rocket. You will travel with the speed of light, rays of light behind me, or no? It was when we started. You will speed with the light using AI and all these features you told us.
Right.
This is my point of view. We must adopt all these changes and we must upgrade our diagnostic level. We must act like doctors and not like imagers. We are doctors, we are medical doctors, and we report clinical examinations. So we are going to find great help from all these tools. I think that the future is brilliant.
Absolutely. Which brings me to one specific question as well, which is because you mentioned about interobserver variability, Dr. Deckers. So when I think about mammography or breast imaging, do you think that with the way these systems, AI solutions are becoming more mature now, that there will be the need in the future of double-blind reading in breast imaging?
I'm not a breast radiologist or breast radiologist.
I am breast radiologist.
Okay, so you should answer this question.
Don't worry.
I think we're seeing there are studies appearing now that suggests, like the Masai study, which you probably know, that suggests that for second reading, AI can do as well. But what bothers me most are the numbers you showed us in the beginning. Remember that the demand for radiology is growing at a rate of 6 to 7% per year. Yep. The inflow of radiological workforce is only 2%. So that's a difference of 3-4%, but that's cumulative. So that's an exponential growth. We're facing huge problems. So perhaps, and this might seem controversial, we should think about a situation where in mammographies or any other diagnostic tests in radiology, where we know on beforehand that the AI has an accuracy of, let's say, 99%, does the radiologist have to deal with that? Because the AI is as good as the radiologist. And we also know from studies that in some cases, adding AI to a performant, a proficient breast radiologist diminishes the accuracy of the radiologist. So in that case, of course, you shouldn't use the AI. And the main challenge we are dealing with now is making the difference between the two. I think that's my personal opinion, we will need the AI in certain cases to decide autonomously. Of course, we will be the responsibles in the end. There's no question about that. There's a European AI Act that's really defined which responsibility is where. But my personal opinion is that in the coming, it's not for tomorrow, it's not for within 2 years, but perhaps within 10 years, the AI will have evolved in such a way that this will become possible.
Absolutely, because what I want to highlight here is also because we do not want to be in a situation where we as humans have to prove to AI that we are not robots. This is the challenge that AI is posing on us, is this AI is asking humans, prove to me you are not a robot. We want to make sure that AI is not hallucinating and providing the right answers. I want to open the discussion to the audience as well. And I would like you to take a snapshot, or if you want to take a picture of this or scan the QR code. This is a white paper that we have published on our roadmap of how we see radiology's transition from PACS to enterprise imaging, and the next 5 years of how we see all this pixel and non-pixel AI, agentic AI, and all these different tools that you hear about is going to be integrated into enterprise imaging, enabling diagnostic imaging workflows for collaboration and communication. I want to open now to the audience for questions and looking forward to the interaction. Any questions? Who will go first? Yes, please.
So when do you think that our scanners will be equipped with AI? So the report will come immediately after the scanning is done, just like what has happened with the ECG measurements? That's my question.
Who wants to take the
That's a very good question. What we see, the AI we are using now, it's like a second pair of eyes, but it doesn't give us much in gain in efficiency. Like for a fracture detection, it takes a few seconds for an experienced radiologist. Also, for even in mammography, you have the same. The amount of time you spend when you do an exam assisted by the AI doesn't diminish. In an ideal case, and we're going to look into that now, we would have, like was mentioned, automated report generation. So that's the next step. People and studies tell us we'll gain 20 to 30% in efficiency there. So that's the next step we'll be looking at. From what I see, it's becoming true, but perhaps this should be confirmed by more studies. Anybody else have any experience?
I think in some ways it depends on the modality. So for example, I mentioned Alliance, there's a lot of PET CT. The nice thing about that is that I get approached by a lot of people who have built an algorithm that are doing something in that space. One of the things I'm starting to see is people have developed segmentation, as you know, so it will draw a region of interest automatically around an area of increased uptake. The algorithms are now starting to be clever. They're starting to measure how big it is, size, volume, radius, and the SUV max, for example.
Yep.
I then just have to click and approve to say that I think it's measured it correctly if I want to double check it. When I do, that now puts it in the report. So I don't have to dictate where it is, what it is, and how big it is, and how hot it is. So I can then just click through all the pathology. I can dismiss if it's picked up some physiological uptake, or I think it's not pathological and it's something else, and I can dismiss it. And it's starting to put that into the report for me. So it's probably saving me a little bit of time dictating all of those findings. Part of that solution is already here. The bit that when I talk to some of these companies, I say, well, then I want you to work out gross tumor volume. And if you've worked it out for this case, can you compare it to gross tumor volume for the previous case and tell me, is it bigger or smaller? So it could do all of that, and I just have to check it's correct. I've accepted or rejected the findings on the image, and I can then hit authorize and it's done. And I've almost not dictated anything. So in theory, I've spent more time looking at the pixels and less time looking at the reporting page. So that's probably 12 to 18 months away, for example, for PET CT. But I think it will be different for the modalities. but some of that is coming on the scanners. So more and more scanners are starting to have segmentation software, anatomical identification software. They're identifying on a CT where the liver is, where the spleen is, what the kidneys are. What's not baked in yet, that I've not seen, but I've not been around all of the stands yet, is are they working out what's normal and what's not? Because for one thing to say there's a liver, but I'm doing more than that. I'm being the doctor. I'm saying it's a normal liver or it's not a normal liver. So it needs to go to the next level. And I think that's a little way off.
Yeah, I agree with you. And I think that the history of lung nodules is a long history. Now all of the software are able to recognize by themselves nodules. Yeah. But now we have some software from CT. When you acquire the lung CT, the system give you immediately the calcium scoring in order to highlight a possible coronary disease and give you some alert for the nodules, and everything works in an automated way. We have also some software for the pulmonary embolism detection. You acquire your contrastographic phase, and in less than 5 minutes, the system is able to recognize the thrombus on the different arteries. So we have a lot of application, but I would say that the AI is not only a matter of diagnosis, it's also a matter of time, because it can speed the acquisition time. We have more reproducibility after during the radiographic acquisition. So in a different condition, the AI will support us for the prioritization and orchestration. We know which is the most important findings we have to look at. And in the emergency setting, again, it's really, really important.
And for oncology patients, we can nowadays follow the result of the treatment, for example, in the liver. So we use it. Now we use it, these reports. We can use it now. And one main thing that I have to mention is that we will be better and better if we can have standardized protocols. For example, in mammography, we have 4 views. So the system must recognize a specific protocol out of 4 views. In cross-sectional imaging, things are very difficult because we have different protocols, different patients, different clinical history. So I think that this process will come in time and for different systems in different times.
If you were all, so we have 2 minutes left, and one simple question. It's $1 million euro question. If you were given €1 million each, what would be your one algorithm? So I need 4 algorithms, so one from you, one from you. What would you want to see embedded in enterprise imaging?
I have to think. Do you have in mind something?
For me, at this point in time, it's clear it's automated reports.
Absolutely. Yes. 2. 3.
I agree. Automated reports, yes, so to save time.
2 million gone. What about you?
You're going to give us?
But someone has to come up with this.
Well, at the risk of again sounding like I'm cheating, if we use £1 million to optimize our protocols and scans, we might generate more money.
Then as compared to, well, you would need automated reporting, right?
But then I'd have them save the money to give them the million.
Absolutely. I think we need to give a good round of applause to our panelists here. And to you, the audience as well. You took time out of your busy schedules at ECR. So we were very happy to see you all. And as I said, our booth is in Hall X2, number 214. Please visit us. We'll be happy to show you all the demo of our solutions. Thank you so much.